Hello and welcome to Get the Big Picture. How does your clinic compare here in Tennessee? My name is Shannon Haynes and I'll be your presenter. I'm the Director of Client Development for Emmaus Consulting. We're a healthcare consulting firm based here in Tennessee. We specialize in taking your clinic to new heights by identifying ways that we can do the things that we hope to help you do on this webinar. The objectives for you, the practice owner or the practice manager, is to identify lost income, help you increase profit, help you reduce claim denials, and to improve the E&M documentation and reimbursement in your clinic. So we hope to take the next little bit to help you do those four things. Did you know that all of your provider prescribing behavior and services that you provide to Medicare patients are all public knowledge? Medicare has decided to reveal the services and pay for all Medicare providers. The Department of Health and Human Services show data of 880,000 providers shows $77 billion in Medicare Part B payments in 2012. In April of this year, Medicare released all the Part B claims data from 2012. They have put a facts sheet on their website, and you can see in the lower left-hand corner of this slide the link where you can read about why they made the decision to release the data, as well as a lot of information about what they gathered from that data. And you can certainly go to that link and review that in detail. And we certainly think you should if you're a Medicare provider. Why is it important for you to know what's included in that information? Well, certainly, since it's all public information now that anyone can see, you, your competitors, other providers, it's important to see, but it's important, the most important for you to see. So it's called the treatment tracker. They took all the Medicare payment data and they put it online through a third-party website, all the Medicare payment data. It compares those providers' 5 visit code ratios to all providers in your state and in your specialty. So when you go to the treatment tracker, it will show your specific code ratios compared to others in your state and in your exact specialty. So whether you're a pediatrician, a family practice provider, if you're a nurse practitioner or a PA, it has all of those averages there. So what it really allows you to do is see where your codes and how your services fit in terms of a bell curve that they like to see there on that website. And so it's important for you to realize how your providers measure up to those state averages. Certainly, if you saw there were abnormal results once you looked at that tracker, certainly that could show you that you might be at risk for an audit. Organized Medicine protested the decision to release this data, as the data doesn't really show the quality of care provided. The Organized Medicine also argued that it violates physician privacy. It doesn't take into account the severity of patients' conditions that present at a clinician's office. So, for example, a physician that treats the sickest of the sick, they might appear to look greedy if they had coded a lot of higher level visits versus being perceived as a provider that cares for the patients that no one else can find a provider to accept them. So certainly that is a concern as far as this public data goes. The other part is that we have found personally inaccuracies in the data. So for example, we have found clinics that showed provider data in 2012 for providers that did not work for our clinics during that same time frame. So we know that this data is imperfect, but we believe it does show a lot of information that you need to see for your providers. So again, why is it important for you to know? So Emmaus Consulting can take you there. If you will use this link here, emmausconsulting.net/treatment-tracker, it will take you to that Medicare public database. ProPublica Treatment Tracker. ProPublica is the website that put all that information and launched all that data. Will compare your provider's 5 visit code ratios and total services provided from 2012 to all providers in your state and specialty based on Medicare Part B billing. Clearly, if you don't take Medicare, then this would not be applicable for your practice. But anybody that had Medicare Part B billing in 2012 will be there. You can use the Emmaus tool called Compare Provider Performance to do this critical analysis. So there's a couple of things that we really hope you learn from looking at this information. The first thing is you will enter the provider data specific to each individual provider in your practice. So certainly it's important for you to see if there's any outliers that may exist. For example, there may be one provider that does a lot more of something than another one, and you can compare the services that each provider is billing to Medicare for that purposes of that data. The other thing is it may ease your mind that you are providing the services in line with other providers in your state. The most important thing that you could find, according to Emmaus Consulting, is that there may be areas that you're losing money. Certainly there may be services that you aren't providing that you could be, that might be valuable to your practice or to your patients. Or there may be services that you're providing that are losing money. It shows you that information for each provider. At that point, you can make an informed decision to maybe meet with the provider to see if it's something that you want to continue to provide. Certainly there are things we do that lose money in our practice, but ultimately are valuable to the patients. A shot of Rocephin is an example. Patients come to the doctor and they want to feel better, and we give them a shot, and we know that we may be losing money on that, but the overall value that provides to a patient isn't clearly shown through the data. A benchmark example for this might be that an average pediatric office would code 40% or more visits as a 99214 or 99215. Now, let's say your pediatric office isn't coding 40% of more as 99214 or higher. So undercoding just 2 patients a day would be a loss of over $1,300 a month, which it calculates out to $16,000 a year. Now that's quite a bit of money. But if you're undercoding 8 patients a day, which Dr. Paul Firth says is more common, could be a loss of $5,000 a month or up to $60,000 a year. So when you use the treatment tracker in your practice, you can see how you compare to other practices in the state in your specialty. So $60,000 a year would be quite significant. Now that $60,000 is money that you could use, for example, to hire an additional staff that might help your providers drive efficiency. So that money is money that you can use to, again, potentially hire additional staff or help your providers do a better job of getting to the next patient, for example. Documentation and coding accuracy is really important. The Medicare Professional Audit System recovered $4.2 billion from audits. So it's very important that you code and you document precisely with the level of service. It's just as illegal to undercode as it is to overcode. And the providers need a clear understanding of coding in order to document appropriately. Now, when you hear the government say they are reducing costs, you should hear that they are taking money out of the clinic owners' pockets. All payers are conducting audits, not just Medicare, but typically what happens is what the government does, all your commercial providers follow behind typically. So they are looking not only to locate overpayments, but they're also looking to identify fraud. And certainly we know that's not something that you are doing, but you need to make sure that you are coding appropriately to help avoid this. Now, there's federal, state, and private payers. They're investigating that the payments are accurate that the payments are necessary, and they are reviewing those payments to locate those overpayments and intentional fraud. What we found is they're actually doing more to locate overpayments than they are to actually identify fraud, which is disheartening, since we know providers certainly aren't intentionally overpaying or receiving overpayments, but certainly the intentional fraud is something we believe they should focus more on, but it's not where their focus is. So, for example, someone billing a 99214 for a patient that didn't even present in their clinic is very different than a provider that codes a 99214 when it may have only been a 99213, for example. Now, in an attempt to control costs, the Centers for Medicare and Medicaid hired a slew of trained auditors to seek out fraud and abuse within the healthcare industry. According to the Chicago Tribune, $4.2 billion that they recovered in 2012 was a record high. Now, these audits are triggered by they harvest the CPT codes based on the claims that you send in, and then these auditors are looking for CPT breakdowns that are outside of the bell curve. So certainly we want to make sure that we are within reason on that bell-shaped curve. If your practice is outside of the norm, it is important for you to know, which is why we wanted you to look through the treatment tracker. And you know that penalties of an audit can be very substantial, especially very financially, can be very big from a financial perspective. Are there ways to avoid a coding audit? We would say there's probably no way to definitively avoid a coding audit, but there are things that you can do to help prevent this from happening. Nancy Enos is part of the MGMA Healthcare Consulting Group. MGMA is the Medical Group Management Association. You may have heard of them because they are the ones who look at, for example, physician salaries across the United States, and they publish those. But she says that there are a few things you can do that you can put into policy in your practice, and you can also put into practice in your clinic that may help. So the first thing we want to do is avoid shortcuts. We don't want to copy and paste, for example. The other things we want to do is use these 3 tips that Nancy suggests here. The first is to use SOAP notes. The second is to banish the word routine. And the third is to document and justify any excess time you spend. So we'll go through these quickly. The first is to use the SOAP notes. That is SOAP, subjective, objective, assessment, and plan. Again, your EMR will most likely guide this process, but if you have not made the shift over to electronic medical records, then certainly you want to be sure you're following this. The subjective portion is what the patient says. The objective portion is what the provider finds during that hands-on exam. So this is what the clinician finds as they touch and observe and listen to the patient. This may also include vital signs and a statement of patient's general appearance. Then we'll put an assessment in place based on what they found, and then the plan of action. So we want to banish the word routine. So we don't want to say they're here for a routine visit, but we might want to say something like we're here to establish care, or they're here for their annual exam. For example, if they're here for too many things, don't be hesitant to have them come back to address other problems. Sometimes, we find they come in, they see you, and they say, oh, by the way, we have these other problems. We have heard that there are certain clinics that have a policy, for example, 1 problem means 1 copay. So just to be sure that your clinic is being paid for the care you provide, you may want to have your providers encourage those patients with multiple problems to come back if that's possible. You want to document and justify any excess time you spend with them. Again, There are plenty of reasons that it takes you longer to spend with a patient, such as test results, educating them on a new disease state, or describing treatment options, for example. But if you include a time element in your documentation, so for example, I spent greater than half the time we were together, 45 minutes, counseling the patient about their depression, then if you include that time element, then the coders can then justify a higher CPT code, for example. The MGMA provides a procedural profile model they call Data Dive. Now, this is something that you can do. You can pay to compare your provider's procedure behaviors in your specific area. And this could alert you, could do the things we've described here in this webinar so far. And there are 100 different specialties you can choose from. It'll cost you between $245 to $535 to do it. But if you really want a very detailed report or a way to maybe help you identify new potential service lines, there's a link here that you can use to go to that. Now, it does have an online portal, and there is an on-demand webinar that describes how the Data Dive works. But you don't have to spend that money in order to get the information you're looking for unless you really want a detailed report. And certainly MGMA is a great place to go for that. But you don't have to pay. You can find out how your clinic compares for free. There are free tools that are available online. You can Google search American College of Physicians. You can also search for the American Association of Professional Coders. But our favorite, of course, is your Emmaus Consulting free resources. There is the link there for you, bit.ly/Emmaus-resources. And it does have our tools available there for you. And guess what? It's free. So here you can see the E&M utilization benchmarking tool that Emmaus Consulting has put together for you to use for free. Now, this is not as detailed as you would get from MGMA, and our benchmarking tool is designed to encompass all primary care specialties. So it includes internal medicine, family practice, general practice, pediatrics, nurse practitioners, and PAs. But certainly I would love to come and do an analysis for your practice. I could provide that. A full clinic analysis is completely free. Once we provide you a plan, then you can decide if you want to come on board with Emmaus. The greatest part about Emmaus Consulting is that we never make a dime until you have additional income in your bank account made from something that we have suggested for you. And this is what makes Emmaus Consulting really stand out from the pack as far as the other consulting companies go. There are two strategies for coding compliance that we really want to discuss. It's important for you to have accurate and specific clinical documentation, and once ICD-10 comes down, which we will talk about in a little bit, in order for it to be successful, they have to be accurately and being specific in their clinical documentation. So it's important that you review the clinical clarification process, so you want to make sure that their documentation is reviewed. There is a good example process that you could follow. There's a link there for you. It's the American Health Information Management Association. They have a really good example process that you could use as a guide if you wanted to put something like this in place in your practice as you prepare for ICD-10. And then maybe most importantly, to implement a compliance plan. A documented plan, not only does it help prevent fraud and abuse, but it also helps the auditors see that you had put in place a plan. So violations may include mistakes by billing medically unnecessary services, coding that's incorrect, or intentional coding for increased or improper overpayment. We want to be sure that we have it in a policy that we do not accept that in our practice. But in order to implement this plan, you've got to be able to train your people. So you can train your providers on the compliance plan that you put in place. There are a couple of things to think about. What is the purpose of the training? So clearly we want to avoid cloned notes. Use your electronic health records absolutely as effective as possible. And then we want to be sure to correct any undercoding and especially any overcoding. We want to code exactly to what they've done. So something to think about is, how do you train your providers? If you do, how often do you train them? And then over time, do you go back and refresh their memory on what that compliance plan is all about? And certainly, if you can document that you have trained, that will really protect you in an audit situation. So there is free compliance training that you don't have to develop from scratch. The OIG has put together some free training. That training has three purposes: to get the facts, so you understand what the law is and what the consequences are if you break it; to have a plan, which is to cultivate that culture of compliance within your organization; and then to know where to go, which is to know what to do if they realize that there's some compliance issues in your practice. This program is free. You don't have to do it, but it certainly is wonderful to have if you wanted to get involved with that program. It is specialized. You can go to a compliance plan that is specific to an independent or small group practice. And then again, it is a positive step in assisting providers prevent those unclean claims or unlawful claims, which we know you aren't doing on purpose. It's just something we want to make sure when the claims go out, they're paid and they aren't incorrect. So I don't want to read you the components of the effective compliance program, but there are components of a program that makes it really a good program. And probably the biggest one here is to have somebody in charge of compliance in your practice. It may be your owner, it could be your practice manager, or it could be somebody that's really would be good at making sure that all of the compliance things in your practice are being done. So it may be an outside person that just comes in to look to make sure that you're doing things the way you say you're going to do them. But again, a big thing is to have open lines of communication between your coders and billers, your providers, and your owners. Certainly you want to make sure that they are able to communicate with one another. A lot of times we find that there isn't a lot of discussion going on between the billers and the coders and the providers themselves, and that can sometimes cause us problems. So we want to make sure we're doing all these things. Now, do you have an in-house coding audit? So there's a few things that you need to know in order to complete a coding audit within your practice. So there is a presentation that you can Google, Coding for Internists, the basics, but certainly there are tons of resources out there online that you can see of how to conduct an in-house coding audit. There are reference sheets that you can also Google, commonly used ICD-9 codes, evaluation and management service codes, and then as we move towards ICD-10, it certainly is going to continue to be even more detailed. So we want to make sure that we are doing these as we get ready for ICD-10. And then making sure you have an assessment tool to determine how your coding compares with those averages that we discussed earlier. And those were just on some of the basic codes, but that gives you a good idea as to where your practice stands in terms of other providers in the state. Now, how can we avoid unclean claims? So clearly, every denied claim wastes time and money. The average cost to rework one claim is $25, and that's mainly in labor, certainly, but it can add 20 to 30% of the cost to that claim. Now, let's say there's 100 claims per month that has to be reworked. Well, that's $2,500 a month. So we want to make sure that we're running reports and finding any problems. Now, this is something that we see across the board that most practices are not doing. So, do you know where those unclean claims are? It could be traced back to one code that there may be miscommunication on. It could be something that's traced back to a person. And it could be something that a simple fix could save a ton of money. Now, there are third-party vendors that will come in to do one of these analyses for you, but certainly if you have a good practice management software, you can run a clean claims ratio report. Now, again, I'm sure that your EMR or your practice management software has all kinds of reports that you know are in there that you don't ever run. Well, we suggest this be a good one to run because you'll be able to see how many what we're calling unclean claims there are, and then hopefully you can do something about it. Most unclean claims come from poor E&M documentation, which is why we want you to focus on a few areas to improve your E&M documentation and reimbursement. Now, there's 5 focus areas that we're going to go through together, and it's important for you to review these with your providers. The first is legibility. Clearly, if it's not documented, it's not done, and you can't code what you can't read. Now, a lot of this has gone away with the advent of electronic medical records, but it still doesn't mean that we don't forget to write something down that we did. So we want to make sure that everything they do, they have written down. So we want to make sure they're doing that. Now, the second thing is you can adopt legibility standards if there's something that, if some of the EMRs has a pen that they can actually write the notes, but we want to make sure we have those legibility standards into our compliance plans. The second part is the documentation orders. So the treating provider who furnishes a consultation or treats a patient for a specific problem and uses those results in the management of this patient's specific medical problem. That's how it has to be. Any test that's not ordered by that treating provider is not considered reasonable and necessary. So if it isn't actually written in the documentation, then a payer does not have to pay for those, any tests that the provider does not deem necessary by writing it in the documentation. The third is they have to record the history. The provider has to do this. A lot of times it's not just sometimes it's the nurse or whoever triages the patient that puts that HPI, that history of present illness, into the documentation, but it really needs to be the provider. The fourth part is to consider the patient status, all the relevant key components. So are they a new patient or are they established? And an established patient means they have received care from you within the past 3 years. So even though they may have been a previous patient, if they haven't seen you in 3 years, they're considered a new patient. And you need to code those appropriately. That's a different code. A key component that you want to make sure to include is how long you were face-to-face with that patient, how much time you spent counseling or coordinating care, and then the substance of what you discussed during that counseling and during that coordination of care. There's a link there that you can read a little bit more there from the American Association of Professional Coders. Finally, with diagnoses, you need to be specific. You want to report the highest number of digits possible. We want to list those codes. Don't code diagnoses. That's anything that is not absolutely sure of. So probable, ruling out, none of those things will work as far as inside of the documentation. We want to make sure to code all the documented conditions at the time of the visit that require treatment. And certainly we can't code anything that's non-existent or that we've already taken care of. There's a few important dates that you need to know. I'm sure everybody sighed a bit of relief when they pushed back the ICD-10 implementation to October of next year. So this is really important that the new compliance date is October the 1st of 2015, and we will continue to use ICD-9 through September the 30th. Are you ready for this? Have you put the things in practice that you were ready when they pushed the date back, or maybe you needed a little bit more time? We're thinking about here at Emmaus Consulting is putting together a series of ICD-10 trainings across the state. So if you would be interested in sending your biller to a day of training specific to ICD-10, you could let us know, and we will certainly, that would encourage us to continue to put those together. So, time to wrap it up. Do you think you have been able to identify lost income through codes that you aren't billing or codes that you might be losing money by providing? Are you undercoding for fear of an audit? Have you been able to reduce the number of unclean claims through what you've learned in this webinar? The second thing we wanted to do was to identify ways to increase profit. So, are you providing services that you aren't current? Are there services that you're providing that you aren't right now? That would help you increase profits. So, identifying lost income, would that allow you to hire staff that might increase efficiency and therefore increase profit? Certainly, we want you to have a strategy in place to help you reduce denials. It could put a significant amount of money in your pocket just because of the sheer cost associated by reworking those claims. And finally, do you feel like you could improve your E&M documentation and reimbursements based on what you've learned today? Just making sure that you're improving those, it helps drive profit, prevent lost income, and help reduce denials. So we hope today that you have learned a lot of things that you're able to do that. And biggest for us is we just want to say thank you. We hope that you have identified ways to help your practice reach new heights. We have barely begun to hike to the mountaintop that Emmaus Consulting would help some of our clients we've helped some of our clients reach. You can email me or call me if you have a question about anything you've heard today on this webinar. My email is there. My phone number is there, or you can, if you feel like you're not reaching the maximum that your practice could be, I'd be happy to come and meet with you to discuss how Emmaus Consulting can help you reach new heights. So we certainly appreciate your time today and look forward to meeting you in person.